Dr. Beverly Reed.
And I'm Dr. Amber Klimczak.
And we are
Two Peaks in a Pod.
Well, hello everybody. Thank you for coming back. Okay, so, whenever somebody comes to see me with a low AMH and they also have infertility, that's kind of a different story because we were kind of more talking about women who weren't trying to get pregnant and they check their AMH. But when somebody is trying to get pregnant, one of my biggest pet peeves is that a lot of women go to other clinics and they hit the door, they say, I'm having trouble getting pregnant, I have a low AMH, and they're told you have to do IVF. What do you think about that?
I know we feel similarly about this, but there are so many other treatment options, and really that person needs to be investigated a little bit more. What is their age? What does the sperm look like? Because there's lots of other reasons why we may be successful doing something like inseminations or IUIs, because keep in mind, you are ovulating each month. Certainly if you're young with low egg supply, I would say many of these women can get pregnant off of IUIs and not move forward with IVF. And to save money, effort, energy, and go through and get pregnant through an insemination, I think most women would want to do that.
Yes, absolutely. So, and I mean, I think too, sometimes I'll start at the very beginning and I'll say, okay, well first, let's make sure this AMH is accurate too. So there's usually two ways to measure ovarian reserve. You can do a blood test, the AMH level, or you can do an ultrasound. You can actually look at the chocolate chips on the cookie, as Dr. K says. I like that. You can look at the little follicles on the ovaries. You can count them to see if it seems like the AMH and the antral follicle count, the AFC, that's what we call it, to see if they match. Because interestingly, they don't always match. Have you seen that before?
Absolutely. And I would say I actually see the opposite way a lot too. I see patients who have really pretty good AMHs, and then we get in to do an ultrasound, and I'm counting their small resting follicles, and they have a really limited number, and it's not congruent. And I'm glad that we have two measures, because I always say we're looking at the whole picture. We're trying to get an estimate based on everything together, and then it helps me to really know, how do I need to dose you? Because these things are all important. It's not just relying on that AMH level.
Yes, yeah. And what I've found, because sometimes if they don't agree, then you have to figure out which to go with. So I had a patient that her AMH came back at like 0.2. I was shocked because I had already looked at her ovaries. She had like 15 follicles on each side, And so I'm like, what is going on here? And so I had to kind of use my judgment to decide on how I'm going to dose her. And ultimately, based on a literature review, I looked at a bunch of studies and really just my own experience too, I chose to really go by what her ovaries were showing.
Absolutely.
And that ended up being the right decision. We got tons of eggs, which you usually should not be able to do on somebody who has a very low AMH. So it could be that this AMH test is sometimes just not accurate on people. So I would say maybe that's one of the first steps in somebody who has a low AMH is get an ultrasound done to make sure that it is actually accurate.
Absolutely. I also use FSH a lot. I know that you don't use it as much as I do, but I trained with Dr. Scott, so I can't not use FSH. So there's another hormone that we haven't really discussed, and this is probably a topic for another podcast, but there is a hormone that comes from your brain called FSH, and it basically talks to your ovaries each month, and it tells them to ovulate. And so what happens is, if you don't have a lot of eggs remaining, your brain has to work really hard to make you ovulate. So it releases higher and higher FSH levels. So we see FSH levels tend to rise as you get closer and closer to menopause. You have to get an FSH level on day 3 of your cycle, very particular. You have to have it with an estrogen level so we can interpret it. So it is a little bit of a trickier hormone to work with, but I love FSH because it does give us a little bit more information. Like there's a lot of data out there to suggest it maybe tells us a little bit more about quality and ultimately end results after going through IVF. So I use both of those. I use AMH, I use day 3 FSH, and I use your ultrasound to kind of estimate what we're working with.
Yeah, absolutely. And then I also like to just go over lifestyle with them because, and it's for a couple of reasons. One is I think it's debatable on whether lifestyle and supplements can increase your AMH level. There's certainly nothing proven that we can do that. But even if that's not the case, I say, look, if we're not going to be working with a lot of eggs, we want to do everything we can to make sure that we've got top quality eggs to work with, okay? And so I have in story, one of the biggest things that I think can really affect eggs that we just don't realize is alcohol use. And to give you an extreme example, this was actually when I was training. I had a patient, she already had a little bit of low ovarian reserve. We were going to be doing IVF. She came in and I went to look at her follicles. They were gone. And I just felt so confused. I'm like, you were just here like 3 weeks ago. You had some follicles. Where did they go? And she said, Dr. Reed, I have something to admit to you. And I'm like, what? And she said, I just came back from Mexico. I'm just going to tell you, I got hammered every day for a week. And I'm like, what do you mean? And she was like, I was just drinking 24/7. Do you think that could have caused it? And I'm like, I don't think so. I'm like, that would be so fast to have that kind of effect or whatever. But I'm like, you know what? Here's the thing. I don't think we should start your IVF right now, whether it was alcohol or not. You just don't have a lot of follicles. Let's just bring you back next month. And she's like, okay, I'm going to clean up my act and everything. And so she came back next week, and sure enough, the follicles were back. Now, I don't know if that was really the case or not, but I will say, in general, my experience has been that when women cut out alcohol, and if they were drinking, for example, 2 glasses of wine a night or something, I do see a great increase in egg quality when they've been able to do that. And there's lots of other things that they can cut out in their lifestyle too. Do you have anything lifestyle-wise that you recommend?
Well, 100% smoking. Mm-hmm. So, you know, and I think there really are good studies. I would say that's the one lifestyle choice that young women can make right now. If you're listening to this podcast, you're in your 20s, you're not even thinking about getting pregnant right now, the one thing I would say to you is do not smoke and stop smoking if you are. Because there are very good studies to show that smokers go through menopause early. Meaning you're probably going to run out of eggs sooner than your peers. You are accelerating the rate of oocyte atresia, or cell death of the eggs. And so I would say absolutely, if my patients are smokers, I tell them cut back as much as you possibly can. If you can't quit entirely. And I find that it's like the time in their life that they're most motivated to make that change. And I say, hey, you know, hopefully soon you're going to have a young baby at home. You don't want to be smoking in the house with a young baby anyways. And that makes a difference. I would say even a pretty quick turnaround I have seen, because for example, I've had smokers that are cycling for IVF. Do the first IVF cycle, don't have a good egg yield. We talk about it. We wait a couple months, we repeat, and we have a significantly higher number response. We get a higher number of eggs. Certainly the quality of eggs is always going to be better when you're not smoking, right? But you know, some of the damage is already done. You know, so it's hard to make, you know, short-term choices to make a big difference in egg quality. But smoking, my gosh, it's the one thing that I really harp on.
Yes, absolutely. And then so I'll review, you know, diet and my exercise recommendations and a supplement list and all of these things. I'm really, again, focused on just trying to help quality, and who knows, maybe it'll increase their number of follicles as well. And I wanted to know, because I just actually had this happen with a patient, have you ever seen somebody's AMH dramatically increase after doing all these things, lifestyle changes and supplements and all of that?
It's interesting. The couple of patients that I've had stop smoking, I don't really repeat their AMH. What I'll do is we'll repeat a cycle, you know, and I see it. So I don't always recheck labs, you know, it's just something maybe I should start doing it and kind of see. And probably it's a bit of a motivator for patients to see, because people like to see numbers change. You know, it's like losing weight on the scale. People like to see that change. So I probably should repeat it. Have I seen AMHs change? Yes, certainly. But I don't know if it's necessarily lifestyle related.
Yeah. Well, let me tell you, I just, so I had one, and I agree too. I don't necessarily usually repeat, but the reason I repeated is this is a patient we had done IVF before, and unfortunately it didn't work. And her AMH was a little low for her age. It was roughly about 2. And then she hit it hard with lifestyle changes, supplements. She did acupuncture. She did all these things. And then she came back and we rechecked, or we did an ultrasound because we're about to do another IVF cycle. And she had so many follicles. And I'm like, your ovaries look completely different to me. But then I was kind of like, am I just being too hopeful? You know how you kind of want to, like, am I imagining these follicles? And so we rechecked her AMH and it had gone up to 6. It went from 2 to 6 in probably about 3 months or so.
Wow, I mean, that's quite a bit of cycle to cycle variation. That's pretty impressive.
I was really fascinated by it. And that's not what I would usually see. I mean, I have certainly lots of patients that have done all the same things that she did. And so that was definitely a dramatic increase.
Was it the same lab?
Yes, it was. Yep,
because we should caution that using different labs to check values and things like that, there can be a lot of assay variations.
Yes, same lab. But anyway, so I definitely thought that was interesting. And it's just nice to know that it's at least a possibility. She is young, so I was thinking maybe that's more likely to happen in a younger person. But I don't know. It's something that I think we really need to be kind of tracking over time in research studies. How does the AMH change over time? is it normal to see drops and rises and all of that? Because I think traditionally we just think of it going down all the time.
That's true. Yeah. What I tell my patients, and even with number of antral follicles, I say it goes like this. And people probably can't see my hand, but there's going to be some months that it's at your highest or your peak. There's going to be some months that it's at your lowest, but it's really kind of cycle to cycle going from, some median levels, maybe slightly higher, slightly lower. And so depending on when you're catching that antral follicle count, similarly with the AMH, there's probably some variation that you pick up on month to month. So
yeah. I think another frustrating point for patients who have a low AMH is they do always want to know why. Why did this happen to me? And I think it's such a good question, and a lot of times we just don't have the answers. I think we do suspect that there's probably a strong genetic component, but then a lot of times they'll say, well, nobody else in my family has this, but sometimes you can have a spontaneous mutation that will occur where you're the first person in the family that may be demonstrating this genetic abnormality. And there are actually some tests that you can do these days to try to dig into that deeper, but my experience has been most people end up not wanting to do the testing because unfortunately it's not covered by insurance, and it is very expensive, like thousands of dollars. And if it doesn't really change ultimately what you do, then I feel like a lot of people don't end up wanting to do it. But
yeah, that's really interesting. I think also, 20, 30 years ago when their mother, maybe have been getting pregnant, this wasn't a thing, right?
Yeah.
And women with low AMH, their mother could have been very similar, but they got pregnant, no problem.
Yeah.
Right? So it wasn't something that they would even recognize. And there's not a lot of good data to show that if you have lower AMH levels, that you're going to enter menopause significantly earlier than the average patient. So, like if it's a 1 to 2 year difference, maybe her mom went through menopause at 48, didn't really think much about it.
Yes.
And so I could see how it could be missed. And there is a genetic component there, but.
Yeah, this actually reminds me when I was in training, I had written a grant proposal because I wanted to do this study. Okay, so have you ever heard of Twinsburg, Ohio? There's this place called Twinsburg, Ohio, and every year they have a twin festival. That's fun. Twins from all over go to this festival, and I always think it's cool. I'm fascinated by twins. And so I'm like, we need to go set up a booth. Maybe we should do this together because I really want to do this.
This is in Ohio?
This is in Ohio.
Let me see how exciting of a place this would be to travel to.
We set up a booth and we draw blood on identical twins and fraternal twins, have them fill out a questionnaire with their lifestyle and all the rest of it so that we can try to determine how much AMH is related to genetics versus lifestyle, right? Because if they're identical twins, they should have the same DNA and everything. So I think that would be a really cool study, but
the proposal didn't go
on. They did. I will say they gave me good comments, like, yeah, great idea, but no. So that's how it is when we're writing research grants. So
I love that.
Should we do that?
Yeah,
that would be fun.
We would have to get the blood back to run it, though. There'd be a lot of blood to be transported.
I know. We have to figure out. Maybe we could talk. Freeze it. We'll be on the plane with a bunch of blood samples. Like, we could do this ourselves.
Maybe only a little bit suspicious to the airlines.
Okay, so then when it comes to treatment options, this is where I really give my patients reassurance because they have usually not heard this until they've come to see me that, you know what, it is okay. This AMH level does not decrease your chances of getting pregnant if we are doing if you're either trying on your own or if we're doing IUI treatment, insemination treatment. And so I actually have an example on my Instagram about this. This is one of the first examples that I came out with because I know there just aren't a lot of stories like this for people to know about. But kind of back to when we were talking about low AMH, it just means that you don't have as many resting follicles at the beginning of your cycle as somebody else does. But that doesn't really matter when you're just doing, for example, an IUI treatment, because with IUI cycles, we're really only trying to get a couple of follicles to grow. So maybe we're trying to get 2 or 3 follicles to grow. Well, if you only have a few to start off with, you are still capable of producing that number of follicles. And so there are studies and data to show that it does not affect your chances of success with IUI if you're trying. And I think that's just such an important message to get out there because, again, so many people are told when they have low AMH, you can't do IUI. You've got to do IVF.
And in fact, IVF, remember, the eggs that we're getting, they're coming from the small resting follicles. Yeah. So women with low AMH, absolutely, you're going to get a smaller number of eggs from IVF. And then it sort of snowballs on you. You feel even more discouraged because you're like, well, they were right. I didn't have a good response to IVF, so it is nice to consider some of these other treatment options before rushing into it.
Yeah, absolutely. With that being said, though, there are times when I am recommending IVF for people who have a low AMH. And so I think some of those come up when we know that there's a sperm problem. If the sperm problem is very severe, then that means we're sort of forced to do IVF. We can't really use those other options. And in those cases, when we're doing IVF, I think it's really important that you don't just do run-of-the-mill IVF. You really need to customize their protocol to target the low AMH. So are there any special things you do on your AMH patient or on your patients that have low AMH when you're doing IVF on them?
Yeah, absolutely. I think one of the biggest mistakes people make is they can overdose them. I've seen people come to me and they show me the protocols that they've been, and they're on 600 units of gonadotropin. So that's the injections, the hormones that you take during IVF. And like we said, let's say you're a young woman with a low AMH. We're hoping that your egg quality is really good. The one thing we don't want to do is affect your egg quality. Okay? I'll tell you, the studies are gray. They're very gray about whether high levels of medications of these injections that we're giving you can affect the quality of the eggs. But I'm a believer. I think that why dose someone above which we know really works. So 450 is my maximum dose. I don't go above it because there's really good studies. So 600 versus 450 doesn't make a difference in outcomes. So why would I dose someone so high and risk affecting their quality that we're trying so hard to maintain? So I think that is something that I'm very, very careful about. And you just want to make sure that we're tailoring it to them, or we're not just blasting them with medications.
And I think it's an easy mistake to make, because I think if you think logically, of course that would make sense. You've got low eggs, we've got to blast your ovaries with as much medication as we had. So I understand why people do it. I understand the logic behind it. But absolutely, there are studies showing that, for example, 600, it just doesn't help. I mean, I guess you could debate on whether it's harmful or not, but it hasn't been shown to help outcomes to go that high.
Exactly.
And here's the thing, that medication is expensive. If you're on that high of a dose every day, I don't even want to know what your pharmacy bill was. So it's just not needed or not necessary. I do want to mention too that, and this is kind of backing up to whether we're deciding to do IVF or not. Okay, sometimes I have people who come in with low AMH, and I'm also recommending IVF, but it's not really because I think they need IVF, but it's because I want them to have the option for fertility preservation.
Absolutely.
So I do think it's really important when I'm targeting them. I always ask them, how many kids do you want to have? And of course, my patients are always so sweet and I say, no, I don't want to know what
your
you'll be okay with.
Family.
Tell me your dream family,
yes.
Because this is our chance to try to achieve your dream family. And I think this is something I've actually really learned over time, because in the beginning I accepted that answer of, if you just give me one, we'll be happy. Because then I would do that, I'd give them the one, and then they come back a couple of years later.
I want baby number 2.
Dr. Rita, right for the second one. And I'm like, well, you told me one. And honestly, sometimes we have struggled with the second one, and then I'm kind of kicking myself because I'm like, I probably should have given them better advice at that time to say, look, let's think about our future selves. Let's help our future selves out and really save some embryos for the future. So sometimes what I'll say is, look, why don't we do some embryo banking? Why don't we save some embryos for the future? We can still actually then just keep those for the future and then try to get you pregnant right now with an IUI, but then at least we've got something later, because what if your AMH goes down even more over time?
Such an important conversation. I would say I have this with the majority of my patients because we see patients that are in their 30s. Let's say our really young patients, even, you're 31, 32, what ends up happening, we get you pregnant right now, we're so happy, but you gestate that baby for 9, 10 months, you deliver that baby, your life is turned upside down, you're breastfeeding, and then they come back to us sometimes 5 years later, and we just don't have the same tools to work with 5 years down the road. So I have this conversation with all my patients, and I agree. Patients are hesitant, and I'm always like, no. And I always say, I'm the youngest of 5. Do you want 5 kids? We'll get you 5. I'm like, how many kids in your ideal family? How many do you want? And I love big families, so I want my patients to have big families.
What's the biggest number anybody has ever told you? Do you know?
My favorite is when there's a large discrepancy between
that's true.
the two. So I feel like it tends to be the male spouse will be like 4, and then the woman will be like 2. Like at the same time, they'll say their numbers. I'm like, okay, we can work with this.
Let's not talk about this. Okay, man.
Yeah, it's pretty funny. But it always tends to be the male, and I guess it's because, they're not growing the children inside them. So.
The highest I've heard so far is 6, and I just heard it like a week or 2 ago too, and I was like so impressed. I'm like, that's right, goals right there. Okay, good. Sometimes that number changes over time too after they have
Absolutely.
It might go up or it might go down.
Depends on how difficult baby number 1 is.
Okay, so one of the things that I find really important when I'm doing IVF is how I'm preparing them for their IVF cycle. So at most places you have some kind of way of getting them ready before they start their injections. And for a lot of places, that means starting them on birth control pills to let the ovaries rest a little bit before we make them work really hard. And I will say that is an important strategy in some cases. Like if you are trying to decrease your risk of having hyperstimulation syndrome, if you're trying to prevent cysts before you're going to be starting the injections. If you're trying to synchronize the follicles, starting birth control pills I think is a great strategy, but I think my personal opinion is if you have low ovarian reserve, you really need to use a more customized strategy.
100%. I do not do an OCP lead-in for my women that have lower ovarian reserve. And Dr. Reed knows this, but I had the luxury of working at a really big fertility center where we could start IVF cycles on any day of the week, no matter what. And I think those women are the ones that really benefit most from a straight start IVF. They can start exactly when their period comes, and we don't even have to do any, sort of tailored lead-in. But we do manipulate cycles so that we can coordinate schedules with our embryology lab and all of that. And so absolutely, I don't use combined OCPs or birth control pills as a lead-in for those patients.
So I'm really into a strategy called estrogen priming. And so the concept with estrogen priming is that about a week after you ovulate, we add on some estrogen medication. And what that does is it actually decreases the FSH levels that come from the brain. The FSH is what usually stimulates those follicles to grow. And the reason that's nice is it really helps to synchronize those follicles. So you know how Dr. K described the chocolate chips on the ovaries? Well, really the ideal situation when you're starting an IVF cycle is that all of those chocolate chips are very similar in size so that they're all lined up like little soldiers ready to go. Because if they're different sizes, then you can get this problem with IVF where you've got some follicles that are ready before the other follicles are ready. And so I found that estrogen priming can be a good way of helping synchronize those follicles. And when you're estrogen priming, it can also upregulate the receptors on the follicles to make them very sensitive to those injections. So it's kind of a way of giving a higher dose without actually giving a higher dose as well. So I'm kind of a fan of estrogen priming.
I agree.
Yeah.
I estrogen prime, I would say, most of my cycles that I have limited egg supply for.
Yeah.
And, what she's also describing is that women who have lower egg supply, your FSH does rise earlier. And so you are the patients that tend to get one follicle quick out of the gates.
Yes.
And it's big. And we go in to do your baseline scan. You're ready to start your IVF injections. And you're like, I already have a 14 millimeter follicle. I only have 6 follicles. That one's going to be gone. So it's very distressing to patients when they see, I already lost one. So the idea is with estrogen priming, hold off that FSH rise that happens naturally, keep it at bay so that they all start to grow with the same FSH that we're injecting.
And, and something recently that I've been doing too, and I think this is interesting, if this is not broadly done, is I've actually started estrogen priming some of my IUI cycles. Because I'm sure you've seen, how women, as they start to run out of eggs, they grow their eggs so fast. So let's say you have somebody that instead of ovulating on cycle day 13 or 14, they're ovulating on cycle day 8 or something. And I know that's a problem. That means that their egg didn't really have the chance to grow and mature synchronized with the lining of their uterus. Their lining didn't get to develop like it should have and all the rest of it. And so what I found is if you estrogen prime them and you do that baseline sonogram, you'll find that those follicles are all small and they'll have a more normal timing to their IUI cycle. It'll let them ovulate later like you would in more of an average person. So I've been using that strategy on some of my IUI patients, and I kind of stole it from my IVF protocols, and it seems to actually be really helpful. So something I plan to continue there as well.
Yeah, and we make it worse for them because we're giving medications that accelerate the rate at which those follicles are collecting fluid, and so then we tend to see a bigger follicle earlier when we're doing IUI cycles because we're giving you medications that do that. So if you're already an early recruiter, we tend to make it worse. So I can see how estrogen priming could help, at least, with the development of the follicle. I don't know about quality because we can't really look at it under a microscope and see how it's fertilizing and things like that. But we'll see. We'll have to track some of those cycles and see the outcomes.
Yeah. One of the other things that I've noticed too is that it can be really important with these patients to avoid too much suppression during the IVF cycle. So usually when we're doing an IVF cycle, we're giving the medications to stimulate the follicles to grow. But as they start to grow bigger, you want to make sure they don't ovulate. And so you give them some sort of medication to keep that from happening, which is important. But also that medication can be suppressive too. So I really like, I think you and I both do it similarly, where we're adding that medication only when it's needed. We're not adding it too early, because I think if you add it too early, it can be suppressive. Would you agree with that too?
Absolutely. So she's talking about the antagonist. If you've been through IVF, you've probably taken cetrotide or ganirelix. We use Provera now, which is a pill, as our antagonist. But traditionally, when you start that antagonist, the idea is that it's actually giving you a little cut in your medications too. And so it's almost like it's lowering the dose that your follicles are really seeing. And so you don't want to do it too early. A cut later is actually kind of nice, because you've already got those follicles growing that you want to recruit. Any of those really small ones that didn't quite make it to that race that's already getting run, we don't want them to grow. So it's okay to kind of cut them off, and that helps when you add in the antagonist, a little bit later in the cycle. Certainly don't want to start it too early. I know Dr. Scott would always tell us, your patient should not be getting a refill on their antagonist. 3 days is plenty. Why do they always asking for refills? And he's right. He said, like, the original studies that were done on antagonist protocols, they really didn't get all of this medication, and it just adds to cost. So,
and I remember looking at the dose finding studies too. They found if the dose was too high, it lowered the live birth rate and everything. So I think the more we can limit that, the better. But of course, we want to make sure they don't ovulate too, because then you lose the whole cycle. So I think that's another important point too. Okay, another strategy that I've started using in the past couple of years is using some sort of method of trying to just select the very best sperm in my patients who have low eggs. So the concept that I try to think of is, look, the average person may get 10 or 15 eggs when they do an IVF cycle. So yes, if you're, doing kind of a traditional way of adding the sperm, that's fine. But in our case, we may only have 1 or 2 eggs. And so in my mind, if you want to fertilize those eggs, you have to be a champion sperm. And so I've been using a method of sperm selection where it's microfluidics. It's these little microfluidic channels. You put the sperm on one side, they have to swim through the channels to get to the other side, and then you take one of those sperm to then fertilize the eggs with. Most of the data on this has been for people who have problems with sperm DNA fragmentation, but the studies have shown that the sperm that make it through have lower DNA fragmentation, and sperm that has been through this little maze produces about 10 to 15% more euploid embryos. And although that may not seem like a big number, I'm like, that could be the difference of an embryo for somebody, and especially when the egg counts are so low, I think it's certainly something to be considered. It's easy to add on. And so that's another thing that I've kind of added on in probably the past year or so with my patients.
Yeah, and it's always nice. It's hard when you're hit on both sides, right? When you're dealing with, maybe you have a male factor issue with sperm and you're dealing with lower egg counts and never but it's just really nice when we have the opportunity to have a good number of sperm to choose from, because embryologists in general do a really good job of selecting really good looking normal shape morphology sperm to inseminate the eggs with. Hopefully you just have enough there to choose from for them to make their jobs easier.
Okay, well, we're going to be wrapping up here soon, but I do want to mention that one of the things Dr. K and I have planned is we are going to check our AMH levels, and we're going to share them with the world. And what we would like you guys to do is try to guess what our AMH levels are going to be. And we're going to do the Price is Right rules. Whoever's the closest without going over, I think it is, right?
Okay, yep.
And so we'll pick a winner for each of us, and I guess we'll give you a gift card. Should we do like a $100 gift card or something like that? And so your way to submit your answers is you can submit on our Instagram. So you could go to either of our Instagrams or Peak Fertility Instagram, submit your answer. We'll probably be doing this, I think, in about a month or so. So you've got some time, but we'll keep track of them all, and then you guys can see what our AMH levels are.
I'm nervous. I don't think
you don't need to be nervous. It's going to be great. I know. I'm like, should we tell them how old we are so that they can? But I'm like, then they're going to cheat. Like they could can try to look it up and see what.
Yeah. Well, I'm one of those people on continuous birth control pills. So
okay.
I don't think mine's going to be very good.
Okay, and I would actually, this was the other thing I was thinking. So, I mean, I guess this will let people cheat. I think my AMH is going to be low because I'm older. But I thought when it comes back low, maybe I'll do the supplements for 3 months and then recheck it, and we'll see. We'll see what happens.
Love it.
Okay, well, thank you guys so much. If you would be so kind and leave us a good review, that would be great. And then if you want to give us any more ideas for topics, that would be awesome too. We'd love to hear feedback as well. And I hope y'all have a great day.
Have a good week.
Bye.